Echo. A very good morning. A very good morning to all our viewers. I welcome you to another online anesthesia postgraduate teaching program. And it's sponsored by Accurella, hosted by A1 Logistics, and our telecast partner is Anaesthesia TV. Today, we have two very beautiful speakers, Dr. A. Ishwaran and Dr. Vinod Kumar Ramachandran. And they will be talking to us about two very important topics, which will be very interesting, I'm sure, for all our postgraduates and our consultants here. The first topic, which will be spoken by Dr. Ishwaran, is on antiarrhythmics for anesthetists and intensivists. A few words about Dr. Ishwaran. He is a consultant interventional cardiologist, and he has his work experience since 2016. He has been working in Karpaga Vinayaga Institute of Medical Sciences, and he is presently at Karpagam Faculty of Medical Sciences and Research. He has been very interested in teaching echo training programs for all postgraduates and consultants. And he is a part of the cardiac stem cell research trial, which is being performed at Karpagam Faculty of Medical Sciences. And its titled Study to Evaluate Safety and Efficacy of Stem Cell Therapy Using Bone Marrow Mononuclear Cells in Patients with Severe Left Ventricular Dysfunction. He is also part of the team which works up cardiac transplant patients and post-transplant follow-up. So I think it's a complete spectrum of a specialty, starting from interventional cardiology to his research. So over to you, Dr. Ishwaran. We are waiting to hear from you. Good morning.
Good morning, ma'am. Thank you so much for those wonderful words. Let me first share my screen. I hope my screen is visible and slide is visible also.
Yes, we see your slides.
Fine. So at the outset, my topic of discussion is antiarrhythmics for anesthetists and intensivists. Myself from Kumaran Medical Center, Coimbatore. So at the outset, I would like to thank Online Anesthesia platform, a wonderful platform for continuous learning for almost they have done for more than a year now. Every Sunday, excellent work by the entire team. And thank you for giving me an opportunity in this elite platform. Esteemed Chief Editor, Dr. Edward Johnson, sir, thank you so much for again having such a very good platform for sharing our knowledge. Thanks to all associate editors, session coordinator, ma'am, Dr. Gomati, ma'am, and Dr. Sarva Vinodini, ma'am, and Dr. Guru Sandhya, ma'am, through whom I got introduced to this platform, and all beautiful listeners on this pleasant Sunday morning. I have framed my discussion with some basic essential info about anatomy of the conduction system, how an action potential is generated and how it is propagated, mechanism of various arrhythmias, antiarrhythmic drug classification, what is old and what is newly added to it. And then I'll move on to peri-op care and ICU setting care with inputs from pre-op assessment, then diagnosis, inputs regarding various incidences and risk factors, and acute management and mid-term management, then moving on to finally long-term follow-up with few inputs on anticoagulation and pacing. To start with, anatomy of the conduction system. As we all know, conduction system is a very peculiar, specialized conducting tissue of the myocardium. We have SI node just situated here near the SVC-RA junction, and from there the current is transmitted via internodal tracts and also into the next atria, left atrium, and then it reaches the AV node here, which is near the Cox triangle, then the east bundle branches, then left anterior fascicle and left posterior fascicle of the left bundle branch, finally Purkinje fibers, and then it reaches the ventricular myocardium. How is the action potential generated and how it is propagated? So sinus node, we all know, is the intrinsic pacemaker. The action potential is generated in the SA node, and then it comes out of the SA node and depolarizes the surrounding tissue. Then it is cell-to-cell mediated conduction via the gap junctions, connections between the cells. That is how the current is transmitted to the entire myocardium. And the specialized tissue, they conduct current faster than the intermyocardial conduction. You can see the action potential of SA node is quite different from that of ventricular myocardium. This is called, we call the phase 4 of the action potential, and there is a gradual upsloping in the phase 4 of the SA node action potential, whereas it is a flat line in ventricular myocardium. This gradual upsloping is responsible for the atomicity property of the SA node. You can see here with correlation to ECG, this is atrial depolarization. This is atrial depolarization action potential. This part is ventricular depolarization QRS, and this is ventricular depolarization of the ventricular action potential, and the remaining part is ventricular repolarization, and this is the ventricular repolarization part of the action potential. So this is the correlation between the action potential and the electrocardiogram surface ECG. If you look closer into the myocardial cells, this is the cell membrane, this is the extracellular space and the intracellular space. When there is a rapid influx of the sodium, there is a sudden upstroke uprise in the action potential complex. From the basic membrane potential of about resting membrane potential of about 85 to 90, it moves to the positive side, which happens very rapidly. So this slope is the depolarization slope or phase 0. Sodium channel is responsible for it. Then sodium channel shuts down and potassium efflux starts. Potassium starts moving out of the cell membrane. This is the phase 1 of the action potential. Then we move on to phase 2, wherein there is a plateau phase. Potassium efflux is counteracted by the calcium influx. So there is balance between the two and it remains as a plateau. Then calcium channels close while the potassium channel still remaining opening. That leads to repolarization. We call depolarization because basic polarity of intracellular cell is negative and that is depolarized and becomes positive. We call it repolarization because it gains back the negativity. And at the resting membrane potential, it comes back to minus 85 to 90 millivolt. So this is with respect to action potential. Coming to the mechanism of various arrhythmias, basically arrhythmogenesis is because of increased atomicity, triggered activity, which is either because of early after depolarization or delayed after depolarization, and finally the famous re-entry. So an arrhythmia can develop only because of these three mechanisms. Either there should be an increased atomicity or reduced atomicity. That should be a triggered activity by either because of EAD or DAD, early after depolarization or delayed after depolarization, and finally the re-entry. This one slide will summarize the various mechanisms. You can see here, this is SA nodal action potential. This one gray color one is a normal one. This is the normal slope of the SA node action potential, phase 4. If the phase 4 slope is rapidly raised, then it is because of sympathetic stimulation this happens and the heart rate is increased. This is increased atomicity. If the slope of the phase 4 is reduced, the heart rate is reduced and this is because of parasympathetic stimulation. So if this more slopey, it's like less slopey, then obviously the rate at which the current travels out of the SA node will be less, so heart rate is less. So this is atomicity. Coming on to early and delayed after depolarization, this component is depolarization until this particular thing, phase 0, phase 1, and some part of phase 2. Anything after the depolarization, if there is changes in the membrane potential, it can happen immediately after the depolarization, that is during repolarization, or after the repolarization is completed. If it happens during repolarization, it is early after depolarization. If it happens completely after the repolarization from the resting membrane potential, it is called late after depolarization. Both these can stimulate arrhythmias. It can trigger arrhythmias. This is atomicity. This is triggered activity. Moving on to our famous re-entry circuit, 2 circuits, one slow pathway, another fast pathway. When a premature impulse approaches this, a trigger can happen, a cycle can set in, and it can result in arrhythmias. So atomicity can be enhanced atomicity, sinus tachycardia, abnormal atomicity, ischemic VT. Early after depolarizations, majority of VTs come under this. Delayed after depolarization, digoxin-related tachycardias come under this. Re-entry circuits can be scar-mediated one, macro re-entry, or ischemia or Brugada-related micro re-entry circuits. Coming on to the drug classification, we all know this famous drug classification, Vaughan-Williams classification. So this is published in late 1960s. So this was holding good and still holding good for many years until now. It's almost like centenary birth year of Vaughan-Williams, but still this is being utilized or being discussed in various forums. Class 1 drug, class 2 drug, class 3 drug, class 4 drug. These are all based on ion channels. Class 1 is simply sodium channel blockers. This is phase 0, which is sodium influx, and this is block, that is class 1 molecule. Class 2 is simply beta blockers. Phase 4, atomicity, that is slope of phase 4 is responsible for the atomicity of the SA node, and there it plays a role, that is beta blockers. Class 3 is potassium channel blocker. We all know potassium channel plays a role in phase 1, phase 2, as well as in phase 3, especially in phase 2 and phase 3. And when this is blocked, the repolarization is delayed, and thereby the action potential duration is prolonged. So this is the class 3 mechanism. Class 4 is the calcium channel mechanism. Nothing but diltiazem and verapamil. This calcium influx, which is in phase 2, is going to be affected here. So just we remember what ion channel is affected in each molecule, and then we can easily remember the effects of the particular class of drug. So this is group 1 drug, acts on the phase 0. It can also affect the potassium channel to a certain extent, whereby it is divided into group 1A, 1B, and 1C. So when it reduces the action potential duration, it is 1B. When it increases the action potential duration, it is 1A. So there is some subtle subtype as well. And group 3 is predominantly prolonging the action potential duration. You can see this is blue one is normal action potential duration. And when group 3 drugs act, it prolongs the action potential duration, which are nothing but potassium channel blockers. Coming to the group 4 action calcium channel blockers, this is again predominantly blocks the calcium channels, which is playing a very major role in the phase 2 of the action potential. Coming to the modern classification, which is published by Lay et al., published in 2018, the centenary birth year to honor Vaughan-Williams. They retained the basic structure, but still added scope for entry of new molecules. A lot of new molecules have come. So 1, 3, 2, 4, all the 3 they have retained, but they have added class 0, which is HCN modulators, nothing but IF, funny current modulators. Then class 5 is mechanosensitive channels, and class 6 is gap junction modulators, and class 7 is upstream modulators. I'll just add upon on the other newer classes alone. HCN is nothing but funny current blockers, which is nothing but the classical example is ivabradine molecule. Mechanosensitive channel and gap junction are research molecules, no clinically useful drug currently available. And class 7 upstream target modulators, nothing but AC inhibitors, ARBs, statins, and omega-3 fatty acids. These 4 group of molecules, the substrate is modified so that arrhythmia risk is reduced. So hence they have added it under the class of antiarrhythmics. This is class 7 upstream target modulators. So class 1, class 0 is HCN funny current. Class 1 is sodium. Class 2 is beta blockers. Class 3 is potassium. Class 4 is all these blue calcium related events. Class 5 is mechanosensitive thing. And class 6 is gap junction or connection related, and class 7 is upstream modulators. This is all about the newer classification as well. We'll move on to topic per se. What is the role in pre-op assessment? I have covered with pre-op, peri-op, as well as post-op and ICU setting. So in pre-op, arrhythmias do occur in majority of acute surgical illness, but that should not defer the urgent surgical procedure in any situation. When surgery is an emergency, it's always an emergency and it is indicated. Arrhythmia, unless it is life-threatening, we don't give much importance to it. Life-threatening arrhythmias, obviously, it will be given preference, but routine, simple, small AF with control rate, we don't think much about it. Some frequent VPCs, we ignore it. We need to document with a 12-lead ECG and do a detailed cardiac evaluation. Prevention of potential triggers is always crucial. So whenever you have an arrhythmic substrate, maintain electrolytes, acid bases in appropriate levels, try to avoid ischemia as much as possible, avoid volume overstatus and hyperactivity of the autonomic nervous system. So these things should be kept. Adequate sedation should be given in those patients. Pain relief should also be adequate. We should always try to avoid a trigger in these individuals. Patient already taking AADs, they should not stop taking these drugs. They should continue to take these AADs during the peri-op period as well, because stopping them can increase the risk of post-op arrhythmias in these individuals. High risk for malignant arrhythmias, always they should have continuous cardiac monitoring. So class 1 recommendation, we have to continue to use the drug whichever the patient was already on in the peri-op period as well. And whenever there is an hemodynamic instability, cardioversion should be done, and then particularly patient should be stabilized and then taken up. And whenever symptomatic ventricular arrhythmias are there, before the surgical procedure, try to treat the ventricular arrhythmias, and ablation of arrhythmias is recommended even before a elective non-cardiac surgery. And definitely asymptomatic VPCs should not be treated. It is a class 3 recommendation. Coming to the diagnosis, this is most very important step. You should know what is a false alarm and what is a true arrhythmia. So many times movement artifacts are there in ICU, and sometimes we consider it as false alarm, and we should know whether it is false alarm or a true arrhythmia. Documentation is must. Unless it is a cardiac emergency, unless it is an ACLS situation or a code blue situation, always take a 12-lead ECG or a rhythm strip before treating the arrhythmia. Many times we see in the monitor and then give therapy to the arrhythmia, but without knowing what arrhythmia actually it is. Monitors are not always completely informative, and 12-lead ECG or rhythm strip is the one which can help us to diagnose arrhythmia and treat. So it should always be done. Documentation most important. If it is a code blue situation, that's a different scenario. I'm talking about otherwise, which is not a code blue situation. Telemetry always indicated in pre-existing arrhythmia and high-risk patient. Onset of arrhythmia and termination should be documented if whenever possible. So if you're going to cardiovert or do something, continuously put them on the rhythm strip and do, so that we will know how the arrhythmia gets terminated. And sustained VT, obviously implication of prognosis is poor, and bradyarrhythmias also we need to identify and treat. So risk factors and incidents. Acute medical conditions are there and acute surgical conditions are there. Sepsis, acute respiratory insufficiency, acute kidney injury, brain injury, cancer-related problems, and acute surgical causes like trauma, burns, non-cardiac surgery. All this can precipitate arrhythmias. Coming to sepsis, obviously increased incidence is there, more than 30% is there. Underlying cause should always be treated, and supraventricular arrhythmias are more common than ventricular arrhythmias. In respiratory insufficiency, pneumonia and atelectasis are the most common causes. And in COPD, AF or multifocal atrial tachycardia is the most common one. Whenever VS is present, it indicates poor prognosis in acute respiratory insufficiency. Acute kidney injury, the mortality is doubled. The incidence of arrhythmias is also doubled than compared to a patient with a normal renal function. And dosing of AIDs need to be given more importance in such situations with AKI. Brain injury, 90% ECG changes will be there. Prolonged QT is a common thing. STT changes are common, and 25 to 30% patients have arrhythmias. Stroke and SAH are the most common precipitating factors. Cancer, disease per se can trigger arrhythmia. Chemotherapy, radiotherapy can trigger arrhythmia, and implanted devices can go in for dysfunction whenever patient goes for prolonged radiotherapy, especially in the breast cancer wherein the device is implanted. So this is regarding acute medical. And acute surgical triggers like burns and trauma, very important. Fluid overload in a burns patient can trigger the arrhythmias. That's again another important thing. And generally they tend to recover spontaneously. Incidence is AF more common with 5 to 15% incidence. Sepsis, AKI all can coexist in burns and trauma. Whenever we think of an arrhythmia following trauma, always think of myocardial contusion as well as a cause of arrhythmia. Electrical injuries can also trigger arrhythmias. Non-cardiac surgery incidence around 4 to 20%. AF is the most common one. 2 to 3 days post-op is usually it's happening, and thoracic surgery is the most common one. Coming to cardiac surgery, 30 to 50% it is AF, and 1 to 5 days is the usual incidence. And complex cardiac surgery involving valve with CABG, the incidence is more. Longer aortic clamp time, the incidence is more. Mitral valve surgeries, the incidence is more. So surgery, very big stress, increased sympathetic tone can result in post-op AF. Ischemias can augment and result in post-op AF, and any things that changes the myocardial stretch can also prevent. That is the reason why hypervolemia stretches the atria and precipitates post-op AF. Coming to the acute and midterm management, supportive therapy definitely indicated. Many patients will require resuscitative care as well. But diagnosis should be confirmed. And if the patient is in unstable hemodynamics, DC version is the treatment of choice. With stable hemodynamics, we can go into the specific treatment. I will come to the algorithm next. And after stabilization, always cause should be addressed. If the patient is unresponsive, not breathing, this is a code blue situation. The entire ACLS protocol, shockable rhythm, non-shockable rhythm, all those stuff can be absolutely carried out as ACLS protocol. If the patient is otherwise okay, but hemodynamically unstable, then elective DC shock is given in such situation. Amiodarone is always indicated in such situation, 300 milligram IV over 10 to 20 minutes and repeated, followed by repeat shock, because pre-treatment with amiodarone increases the chance of cardioversion. And otherwise, if the patient is not hemodynamically unstable, otherwise hemodynamically stable situation. I'll come to the next algorithm. Always we should try to identify the reversible causes and treat. The various H's and T's we know, we have to identify and treat them. So I'll discuss with respect to atrial fibrillation and then SVT and then VT. So atrial fibrillation, obviously higher ventricular rates and loss of atrial kick. Those two things are responsible for the hemodynamic deterioration. And whenever there is hemodynamic deterioration, DC cardioversion is needed. Sedation, appropriate intubation if aspiration risk is there, otherwise we can go ahead. Anteroposterior lead placement is superior than the lateral lead placement, and biphasic is always superior than the monophasic. 200 joules is the number we need to remember. And pre-treatment with the antiarrhythmics, especially amiodarone, facilitates DC version. And generally, in critically ill situations, the success rate is low because the cause is not treated. So it's otherwise in a routine OP setup, if you see, immediately they will get cardioverted. But here, the cause is not treated. If the patient is critically ill, continue to be critically ill, so success rate is only 30 to 40%, and he need to continue antiarrhythmic agents in these individuals. So new onset reversible manifestation, more than 50% it reverses in 72 hours. Stable hemodynamics, rate control versus rhythm control. So beta blockers, calcium channel blockers, digoxin, A, B, C, D. Beta blockers, calcium channel blockers, and digoxin. All these three are used for rate control. A is for rhythm control, amiodarone, and magnesium is also used for pharmacological cardioversion. And always in post-cardiac surgery situation, amiodarone and beta blockers, those two are the commonly used one. Whenever there is LV dysfunction or hypotension situation, we will avoid beta blocker and prefer amiodarone in this situation. And always rate control versus rhythm control is a big argument. And initially, we always try rate control. And if the patient is still hemodynamically unstable, we can think about rhythm control even in acute AF situations. And very lenient versus strict is all symptom driven. If the patient is otherwise asymptomatic, we should not be that aggressive. And thromboprophylaxis is always indicated whether it is paroxysmal or non-paroxysmal, whether it is rate or rhythm control therapy is followed. Always you should think about thromboprophylaxis, but the biggest challenge will be thrombocytopenia, bleeding risk, or invasive procedures are always there. And atrial flutter is similar to atrial fibrillation, but only thing is low energy DC cardioversion is used in this situation. Ventricular tachycardia, supraventricular tachycardia, either because of atomicity or re-entry, AV-NRT, AV nodal re-entry tachycardia, AV-RT or PGRT, the common one. Simple vagal maneuvers will stop AV-NRT and AV-RT. If it is not getting stopped, it is usually atrial tachycardia. Intravenous drugs, IV adenosine, 6 milligram bolus. Subsequently, if we want to repeat it, we can repeat with 2 doses of 12 milligram if necessary. And IV calcium channel blockers like DTSM or MIL and IV beta blockers are also used in this situation. SVT with aberrancy versus VT, this difference is very, very important. If you're not able to differentiate, obviously we should always treat it as VT unless otherwise it's proved to be SVT. Amiodarone is preferred in patients with impaired ejection fraction and cardioversion if unstable hemodynamics is there. So this is the narrow QRS tachycardia versus wide QRS tachycardia in a hemodynamically stable patient. Think whether it is regular or irregular. Regular, P is very clear, it is sinus. If P is unclear, it's either AV-NRT or AV-RT or AT-AF. So vagal maneuvers will stop AV-NRT or AV-RT. Vagal maneuvers will not stop atrial tachycardia or atrial flutter or sinus tachycardia. So based on this, you can differentiate them. Coming to wide QRS tachycardia, it is irregular, more likely polymorphic VT. And if it is regular, 1:1 relationship, if it is present, always think about a ventricular tachycardia. You should always analyze the bundle branch block pattern. The entire thing is discussed by a Brugada criteria and it is out of scope of discussion. It's RBB typical versus atypical pattern. If atypical pattern is there, it suggests a ventricular tachycardia. Ventricular rate is more than atrial rate, it again suggests a ventricular tachycardia. Newly diagnosed AF, acute management is always clinical assessment and anticoagulation. Unstable, always DC cardioversion. In stable, 2 point comes here, rate control versus rhythm control. Rate control, B, C, and D. Beta blocker, calcium channel blocker, and digoxin. Amiodarone is also used for rate control, but ideally it is a drug of choice for rhythm control as well as class 1C agents. If follow-up after ICU care, try to identify the cause and treat the cause. We should always think about anticoagulation. Whenever the risk of bleeding is low, we have to think of anticoagulation. When risk of stroke is more, again, we have to think of anticoagulation. And long-term therapy is indicated. Ventricular premature complexes and non-sustained VT, if it is isolated, less risky. PPCs and NSVT, we need not be very aggressive. Only when the patient has hemodynamic instability, we'll think about correction of causes. Whereas ventricular tachyarrhythmias, if it is sustained monomorphic VT, mortality is more, 50%. Pre-infarction VT is more likely. If it is unstable, 200 joules biphasic shock is always necessary. Sedation is required in an awake patient and risk stratification. And then if the patient needs ICD implantation, we have to go ahead with ICD implantation. Ventricular fibrillation, immediate defibrillation is done. Amiodarone is given after 2 to 3 shocks. Post amiodarone also we can try reverting the patient again and may require vasopressors with ABP and all the other hemodynamic support. And torsades point is QT prolongation is the commonest cause. If QT prolongation is not there, ischemia and severe LV dissection, we should always think about isoproteinorol may be useful in these situations. And coming to ventricular arrhythmias, which is incessant VT and electric storm. If it is persists more than 12 hours, we call it as incessant VT or electric storm. More than 3 times in 24 hours, requiring interventions. That is also again incessant VT or electric storm. We should think about ongoing ischemia and try to correct the correctable causes. Mostly the patient will not give more than 12 hours to 24 hours. Meanwhile, they will succumb to the ventricular tachycardia. And proarrhythmia should always be considered in these individuals if the patients are already on antiarrhythmic agents. And coming to the ventricular arrhythmias, unstable, directly it is electrical cardioversion or defibrillation. Stable, ventricular premature contractions and non-sustained VT. Asymptomatic, don't do anything. Symptomatic, beta blocker and lignocaine. Sustained ventricular tachycardia, amiodarone is a treatment of choice. You can think about procainamide and lidocaine or finally electrical cardioversion. VF, obviously it is defibrillation. Persistent ventricular tachycardia or paroxysmal ventricular tachycardia with torsades, some polymorphic ventricular tachycardia with torsades point is electrolyte correction, magnesium, isoproteinorol, temporary pacing. If QTC is normal, always think for ischemia. So in torsades point is with normal QTC, think about ischemia always. Incessant ventricular tachycardia and electric storm, ischemia, electrolyte abnormalities, and proarrhythmic agents. Always defibrillation combined with antiarrhythmic drug is the treatment of choice in this. So common drugs. Amiodarone 150 milligram over 10 minutes, 1 milligram per minute, that is 60 milligram, 6 hours, and then 30 milligram, 18 hours. And maintenance dose is again 30 milligram per hour. This is the commonest one. And metoprolol, again 2.5 milligram or 5 milligram over 1 to 2 minutes, can be repeated up to 15 milligram over 15 minutes time. Verapamil and diltiazem are doses 0.25 and 0.075 to 1.5. So all these things we can remember. These are the commonly available drugs. Amiodarone, metoprolol, diltiazem, verapamil are commonly available agents in the management of all these arrhythmias. Coming to some anticoagulation issues, postoperative AF, which is prolonged for more than 48 hours or longer, obviously they need anticoagulation. If with warfarin 2 to 3 INR level, novel oral anticoagulants like dabigatran can be indicated. And 3 weeks prior to cardioversion and 4 weeks after cardioversion, it is definitely required. So even though it is a temporary postoperative AF, these patients require anticoagulation for at least 4 weeks. Coming to the pacing and devices, in patients with acute myocarditis or pancarditis, presence of high degree AV block, presence of symptomatic bradycardia, presence of bradycardia dependent ventricular arrhythmias. All these 3 things, they require pacing, temporary pacing support. Patients with cardiac surgery or TAVI or heart transplantation surgery, symptomatic sinus node dysfunction or symptomatic AV nodal dysfunction. Both these things, they require pacing. So it's myocarditis and pericarditis or pancarditis, cardiac surgery, TAVI, and heart transplant. In all these subsets, significant symptomatic high degree blocks and sinus node dysfunction, they require pacing. And long-term follow-up, risk of stroke, heart failure, and mortality definitely is more in these patients who developed AF in critically ill situation than patients without AF. So obviously these patients should be followed up for long-term, followed up for precipitation or recurrences of AF in these individuals or arrhythmias in these individuals, and they should be treated and evaluated appropriately. Similarly, any patient with ventricular tachyarrhythmias, a complete cardiac evaluation to assess the cause of ventricular arrhythmia is always indicated, and patients should be appropriately treated and appropriately managed based upon the risk factor which these patients have. To summarize the discussion, conduction system is a specialized tissue. Atria or ventricle are completely insulated from each other apart from AV node and his bundle. So obvious AV node and his bundle is the only way through which atria can depolarize the ventricle. So it propagates in a particular fashion. Sinus node is the pacemaker cell and it generates impulse and propagates to the adjacent cells. It reaches via the conduction system to the entire myocardium. So the generation is from the AV node. Propagation occurs through from the SA node. Propagation occurs through from the AV node, his bundle. And you need to remember, it is always from endocardium to epicardium is the direction in which the current travels. And we should always remember, it is from the apex to the base the current travels. So these are the 2 important things regarding potential generation and propagation. Arrhythmia mechanisms, atomicity, triggered activity, and re-entry circuit. Coming to the antiarrhythmic drug classification, it's older one, class 1, class 2, class 3, class 4. Class 1 is sodium, class 2 is beta blocker, class 3 is potassium channel blocker, class 4 is calcium channel blocker. And to this, we have added three more things to become 8. So class 0 is nothing but HCN or funny current evaporating. It is a molecule for class 0. And class 5 and 6 are not commonly used ones. So mechanosensitive channels and connection related channels. And class 7 is upstream molecules like AC inhibitor, ARB, and statins, and omega-3 fatty acid molecules. Coming to the pre-op care, in pre-op assessment, we have to identify the risk factor for arrhythmia, and those patients should be monitored properly. Diagnosis is more important. Documentation is very important. Any patients with risk factors, we should carefully follow for onset of arrhythmias and treatment of appropriate arrhythmias whenever the hemodynamic compromise occurs. Acute and midterm management, if unstable, single answer is DC cardioversion as much as possible, and then pharmacological cardioversion whenever it is indicated. When the patient is stable, look for the arrhythmia type, atrial flutter, atrial fibrillation appropriately managed, ventricular tachycardia and ventricular fibrillation appropriately we have to manage. Single drug, if you want to answer here, amiodarone is the single drug of choice. Entire discussion for 30 minutes, and finally, if you want one answer, I will give 2 words. One is DC cardioversion if unstable, if stable, amiodarone. That is the simplest message which we can take from this session. Anticoagulation obviously have issues because of trauma and bleeding related issues. Pacing and devices, definitely we need to consider in a high-risk situation with symptomatic bradycardia, both involving SI node as well as AV node. And long-term follow-up, these patients have increased risk of atrial fibrillation and ventricular arrhythmias. So the risk factors should always be identified and treated appropriately. And with this, I would like to summarize my session with big thanks to the entire online anesthesia platform, to its chief editor, sir, and associate editors and session coordinator, ma'am, as well as everyone who have patiently listened to this. Whenever given an opportunity, I will be happy to see you all again. Thank you so much.
Thank you, Ishwaran, sir. That was an intense topic, and you've covered an enormous topic within your time. I have one question to you, sir. When we have arrhythmias associated or dyselectrolytemia and arrhythmias, so how difficult, how in your experience, how difficult or how easy is it to treat, and how should we go?
So obviously,
and which is a common.
Yes, ma'am. As you said, it is one of the precipitating factor in most of the situation. So dyselectrolemia is the most important precipitating factor for all arrhythmias, especially post of AF, POAF, post of atrial fibrillation. And these patients, we have to parallelly correct the dyselectrolemia along with the correction of arrhythmia with either antiarrhythmic drug or whatever therapy. So that is the reason I have also mentioned that cardioversion in these patients have only 30 to 40% success rate, because background dyselectrolemia will be there. So simple shock will not correct all problems. Shock will temporarily correct, immediately it will revert back to the AF. We have done it many times with futile attempts. 2-3 shocks we have tried and still the patient won't revert to sinus rhythm. Finally put them on amiodarone infusion for 24 hours. Along with that, correct whatever electrolyte abnormality is there. That is the way to go, and obviously it should be corrected along with antiarrhythmic agents.
Okay. Yeah. Have you ever come across any difficult patients where you found it very difficult to revert back to normal sinus rhythm?
Yes, ma'am. Many times we have come across when my anesthesia colleagues in the same forum will know. Many times we were unsuccessful in reverting to sinus rhythm, ultimately resorting to only rate control drugs. And even we had last week, we had one patient who was continuously in atrial arrhythmia with rate of 120 to 130. We could never bring it back to below 100 for more than 1 to 2 weeks time. Ultimately, we even lost him because of some other pulmonary and fulminant pneumonia. But this we could not revert him at all. His cardiac function is otherwise normal. He did not have any other problem. His electrolytes were also ultimately normal. Only thing is he got fulminant pneumonia in the background of retroviral disease. So only that was the precipitating stressor, and we could not revert him at all for almost 1.5 weeks. He was still 120, 130 heart rate, and aggressive drugs only deteriorated his hemodynamics, and ultimately he was in sepsis and we lost him. And this is a challenge always, ma'am. Recently, we had one Burns patient who had persistent tachyarrhythmia. Volume overload also was a reason, and electrolyte abnormalities were more importantly the important reason. We collected electrolyte abnormality, but still AF, it was very, very resistant. ultimately, sadly, we lost her as well. And these are some patients who are critically ill, and they pose a big challenge to cardioversion or pharmacological as well as DC cardioversion.
Yeah. So if we have any patient with sepsis and burns, we have to be very careful.
Absolutely, ma'am. Absolutely.
This is a beautiful
Aggressive volume
presentation.
correction in sepsis or as well as
Sepsis.
burns also precipitates arrhythmias, especially atrial arrhythmias, AF. So we should be careful in that as well.
Excellent. Thank you so much, Vinod sir. You have given us a beautiful presentation and an eye-opening lecture. And your PPT was spot on. Beautiful, illustrative. Thank you so much. Thank you so much, sir. We do not have any questions. If there are any questions, we can take it up in the chat box, sir. Thank you so much. Thank you. Over to our next topic will be by Dr. Vinod Kumar, and he will be talking to us about abdominal interfacial blocks. And a few words about Dr. Vinod Kumar Ramachandran. He is an MMC postgraduate alumni, and he's also working at Kumaran Medical Center, Coimbatore. He's an anesthesiologist and intensivist. And he's a very avid postgraduate teacher, and he has huge interest in training BLS and ACLS in both postgraduate students, nursing, technician students, as well as college student volunteers. I'm very happy to see that he's doing that all BLS training for training college students. And his main areas of interest are ultrasound guided regional nerve blocks and anesthesia for interventional radiology and cardiology. So over to you, Dr. Vinod sir. Dr. Vinod.
Good morning, everyone.
Yeah.
Myself, Dr. Vinod Kumar from Kumaran Medical Center, Coimbatore. And I would like to thank Dr. Edward Johnson, sir, and the entire team for this organized, excellent online platform and for giving me this opportunity. And I would like to extend my thanks to all my professors and teachers of Madras Medical College and the Medical Center. Today we'll see abdominal wall blocks. Why we need to know abdominal wall blocks? Here are the few important points. Easy to do with ultrasonogram. Postgraduates can learn and do the block with ultrasonogram. Little risk of adverse events, reduced opiate consumption in the postoperative period, and definitely alternative to the central neuroaxial block. And it provides some good analgesia, as well as recent cadaveric study shows it provides some visceral analgesia also. So another few important points. In the last decade, increasing minimally invasive lab procedure. So we may not require epidural always. We can go with interfacial abdominal wall blocks. And aggressive postoperative anticoagulation regimen is nowadays increasing. So it is very difficult to manage with the epidural catheter in situ. So we can go ahead with the facial blend blocks, and early ablation also possible with the interfacial plain blocks. These are the major classification of the abdominal wall blocks, divided into anterolateral wall and posterior wall. In anterolateral wall, there are 3 blocks. Usually we do rectus sheath block, transverse abdominis plain block, and ilioinguinal iliohypogastric nerve block. In the posterior wall, again divided into 3: transversalis fascia plain block, quadratus lumborum block, and erector spinae plain block. We are going to see all blocks except erector spinae plain block today. This is a very important slide. This is an innervation to the anterior and anterolateral abdominal wall. You can see here the sensory dorsal root ganglion and motor ventral root ganglion unite to form the spinal nerve. The spinal nerve exits from the intervertebral foramen, divides into ventral and dorsal rami. Ventral rami is the most important branch for the anterolateral abdominal wall. In ventral rami is again You can see here again divided into lateral cutaneous branch and anterior cutaneous branch. Lateral cutaneous branch again divided into lateral and anterior branch to supply the lateral wall of the abdominal wall, and the anterior cutaneous branch runs anteriorly to supply the anterior abdominal wall. You can see in this image, anterior cutaneous branch supplies a major part of the anterior abdominal wall, whereas lateral cutaneous branch supplies the lateral part of the abdominal wall. In the bottom of the image, two more branches you can see, ilioinguinal and iliohypogastric nerve also supplies the lower part of the abdominal wall. Usually it arises from the lumbar plexus, but ilioinguinal nerve studies shows ilioinguinal nerve consistently arises from the lumbar plexus block, whereas iliohypogastric nerve sometimes arises from the L1 and sometimes arises from the T12 branch also. You can see the muscle arrangements in the anterolateral abdominal wall. Hope all PGs are aware of this. All three flat muscles, external oblique, internal oblique, and transverse abdominis, and vertical paired muscle, rectus abdominis muscle. And here important point is arrangement of the fibers, infero-medially, external oblique, superior-laterally, internal oblique muscles. Fibers crossing each other. It is very important to, I will tell you later why. And in the right side, you can see the reason nomenclature says there are multiple vessels and involved in interfacial plane blocks. You can see superior epigastric artery, inferior epigastric artery, and deep circumflex iliac artery. When you do a rectus sheath block, you can chance of accidental arterial puncture is also possible, because usually we may think interfacial plane blocks are always avascular, but the recent nomenclature says there are vessels also involved in the interfacial plane blocks. Deep circumflex iliac artery, when you do inguinal nerve block and iliohypogastric nerve block, you may puncture deep circumflex iliac artery also. So careful aspiration of the careful aspiration before the block is needed. These are the major blocks in the anterolateral abdominal wall. You can see midline. You can do rectus sheath block in the subcostal plane, subcostal tab block, in the mid-axillary line, posterior or lateral tab block, and in the, just above the iliac crest, anterior tab block, which is nothing but targeting the ilioinguinal and iliohypogastric nerve block. Why we need different locations for the abdominal wall blocks? Here you can see in this image, left side of the image, three important vertical lines: mid axillary line, anterior axillary line, and mid clavicular line. And in the lateral view also you can see additional posterior axillary line. This is very important. Why? Because T6 to T9, it means upper thoracoabdominal nerves usually enters the tab plexus here. It means medial to the anterior axillary line, whereas lower thoracoabdominal nerves T10, T11, T12 enters the tab plane more laterally, and ilioinguinal iliohypogastric nerves usually passes and enters the tab plexus just above the anterior superior iliac spine. So these are the multiple locations nerves entering the tab plexus, tab plane. So because of this reason, we need multiple site for the to block the nerves. Common, all interfacial plane blocks can be done with the linear pro high frequency, except quadratus lumborum block, which needs curvilinear pro to perform the block. always have with this whenever you perform the block. Go with the standard nerve block tray, 22 gauge stumiplex or spinal needle, and drugs 0.25 bupivacaine or levobupivacaine or 0.2 ropivacaine, and always follow the standard aseptic precautions to avoid the infection. This is a common image we used to see. Rectus sheath block is supraumbilical, infraumbilical. There is a difference. The posterior rectus sheath in the supraumbilical region is formed by aponeuroses of the internal oblique and transverse abdominis, below which you can see transversalis fascia. Whereas in infraumbilical region, there is no posterior rectus sheath, especially below the arcuate line. Only anterior rectus sheath you can see, which is formed by all three oblique muscles. This is very important image. You can see the thoracoabdominal nerve enters the rectus sheath, anterior branch. As I said earlier, anterior branch enters the rectus muscle in the lateral edge of the rectus abdominis muscle, pierces the rectus sheath, and anteriorly goes and supplies the abdominal wall. So try to locate the trach here in the lateral edge of the rectus abdominis muscle. In the left side of the image, you can see the aponeurosis joins to form the rectus sheath, and in the midline, it forms a linea alba. The posterior rectus sheath is unsegmented, so after deposition of the local anesthetics, it spread easily, more cranially as well as caudally. In this zone anatomy, you can see the two in the posterior part of the rectus abdominis muscle. You can see the two important hyperechoic line. The above one is the posterior rectus sheath, and the below one is the fascia transversalis. So our idea or aim is to deposit the drug above the posterior rectus sheath, and the muscle belly should be lifted up after the drug deposition. So keep the transducer in the transverse orientation, either above or just below the umbilicus. It depends upon the incision. And you can see the rectus abdominis muscle. And in the right side of the image, injection site is the lateral edge of the muscle, and avoid puncturing the superior epigastric artery. You can start from the midline. You can see the linea alba. Once you keep the probe in the midline, slide the probe laterally. You can see rectus abdominis muscle and the posterior rectus sheath and fascia transversalis. And once you move laterally, you can see the transverse abdominis starts to appear. Here is how to do block. Needle entering from the lateral to medial direction. You can do in the out of plane technique also. Once you enter the rectus muscle, try to reach the posterior part and keep the needle above the posterior rectus sheath. You always check with a small volume of normal saline. Yes, you can see we are maintaining the two hyperechoic line below the drug deposition, and muscle belly is shifted up. The drug is deposited between the muscle belly and the posterior rectus sheath. You can see the nice drug spread here. Muscle belly is above and posterior rectus sheath is below. Okay, 20 ml is needed for midline laparotomy. Above and below the umbilicus, you can deposit each quadrant 10 ml of 0.25 bupivacaine or ropivacaine. Common complications: hematoma, peritoneum or bowel puncture, which is immediately below the rectus muscle. So always try to visualize the needle tip. And accidental puncture can cause local anesthesia systemic toxicity, but it is very less with the ultrasonography guided blocks. So here the important tips: extends more laterally rectus muscle than we think. So always, even with the dressing is on, we can do the block. And always rotate the probe 90 degrees and see the cranial and caudal spread. And always use a Doppler to confirm the vasculatures. Somatic analgesia for the midline, bilateral injection is required, and divided injections superior and inferior to the umbilicus provides better spread. This is very important. And transverse abdominis plain block, this various types. First, we will see the subcostal block. It provides analgesia to the T6 to T7 dermatome and some to extent T9 and T10 also. You start scanning from the zipisternum and keep the probe parallel to the costal margin, and you slide the probe laterally. You can see the oblique muscles and deposit the drug between the transverse abdominis and rectus abdominis and transverse abdominis. You can see the linea semilunaris where the transverse abdominis start to appear muscle. You can deposit in between the rectus and the transverse abdominis. In between the rectus and transverse abdominis, you can see the drug deposition. We'll go through the pre-block scanning. Start from the zipisternum and move the probe laterally. You can compare the image and the ultrasonogram image. Rectus abdominis. After that, the transverse abdominis start to appear, and you can see the midline semilunaris, and all oblique muscles will appear if you slide the probe more laterally to deposit the drug. Once the transverse abdominis start to appear near the semilunaris. Here you can see the block. The needle is entering from the lateral to medial, or you can perform from medial to lateral direction also. Always in plane is ideal. We're trying to reach the, yes, here you can see the drug spread between the rectus abdominis and transverse abdominis muscle. Elliptical shape is a shape of local anesthetic drug deposition. You can see, you can visualize the needle tip also. Here is the drug spread of the subcostal tab block. It provides analgesia to the T6 to T7 and sometimes up to T9, T10. But very important point is it will not cover the incision lateral to the anterior axillary line. Next, we will see the posterior or lateral tab block. Here, as I said earlier, the ventral rami is divided into lateral and anterior cutaneous branch. So you perform in the mid axillary line to block before getting divided into branches to block the both branches. It mainly covers the T10 to L1, but sometimes ilioinguinal and ilioepagastric nerve missed because of the anatomical variation, which may need additional injection. In the left side of the image, you can see the entry point. It is 2 centimeters away from the transducer edge, because you can in the image always compare the depth of tab plane and take the entry point away from the transducer to visualize a needle better. Keep the probe in the mid axillary line and try to inject the local anesthetics in the transverse abdominis plane near the tapering end of the transverse abdominis. This is pre-block scanning. To start from the midline, you can see the rectus abdominis. Once you slide the probe laterally, you can visualize all 3 oblique muscles, external, internal oblique muscles, and tapering end of the transverse abdominis muscle in the mid-axillary region. Needle entering from the lateral, medial to lateral or lateral to medial direction. You can do the block either in the supine or lateral position. You can see the drug deposition. Initially, the small volume is injected in the internal oblique itself, and you always advance the needle beyond the transverse abdominis plane and withdraw the needle, and always check with a small volume. Once you inject the drug, try to reach the corner or more laterally to open the plane further. See, here we are advancing the needle towards the corner to open the plane further, so it provides better analgesia. So don't deposit above the internal oblique, below the in between the in the transverse abdominis plane is above the transverse abdominis and below the plane. Don't deposit inside the internal oblique muscle. It provides somatic analgesia for the lower abdominal wall, T10 to T12 and up to L1, but it will also not cover the incision lateral to the anterior axillary line. And as I said earlier, L1 is not consistently covered. Even sometimes after tab block, patient may complain pain because of sparing of L1 nerve. It needs additional ilioinguinal and iliohypogastric nerve block. Usual volume is 25 to 30 ml. There is a small difference between the posterior and lateral tab. You can see probe is placed above the iliac crest in both, but it is more laterally in the posteriorly in the posterior tab, and drug is deposited near the tapering end of the transverse abdominis. Whereas you can key in the anterior to mid axillary line in lateral tab, deposit in the transverse abdominis plane. But a few studies shows posterior tab block provides more effective and prolonged analgesia than the lateral approach. So for the lower abdominal surgeries, especially cesarean surgery, you can do after wound closure, and you can do in the post-operative period. If the patient complains pain, you can again top up the block after 4 to 6 hours. And if the patient is allergic to NSAIDs or opiate dependent, you can do the transverse abdominis plane block. In our center, we are regularly doing the transverse abdominis plane block. It provides better analgesia. Previously, obstetricians also hesitant to accept this, but nowadays they told there is a significant reduction in the overnight opiate requirement. But always combined with the multimodal analgesia concept with the paracetamol and tramadol. What is dual tap and 4-quadrant tap block? It is for the both upper and lower abdominal incisions. It can cover the entire abdomen. You combine with the subcostal plus either lateral or posterior tap block. It is called dual approach. If it is done bilaterally, it is called 4-quadrant tap block. So whenever there is a large incision, you can go ahead with this. Important few tips. Use a tectonic sign to define the layers, because in obese patient, it is very difficult to locate the muscles because the interference of the subcutaneous and fat tissue. Here in this video, I'll show you how to identify the cross arrangement of the fibers. You can see 2 trains crossing each other opposite. And calculate your entry point to result in a horizontal needle trajectory. And keep moving your needle into the corner of the pocket to open it further. It provides better analgesia. Again, in this video, you can see arrangement of the fibers, 2 trains crossing each other. And here, finally, ilioinguinal and iliohypogastric nerve block. You can see the dermatome. Iliohypogastric nerve supplies the suprapubic region, inguinal region, as well as the upper lateral thigh. Whereas ilioinguinal nerve supplies the inguinoscrotal region. Keep the probe above the anterior superior iliac spine. It actually ilioinguinal and iliohypogastric nerve emerges from under the psoas major and runs anteriorly to the quadratus lumborum muscle, and initially runs deep to the transverse abdominis. After that only it enters the tab near the anterior 1/3 of the iliac crest. This is the reason we miss in 50% of the lateral or posterior tab block, so which needs additional injection in the just above the anterior superior iliac spine. You can see the hypoechoic nerves here, ilioinguinal, iliohypogastric, and sometimes T12 branch also you can able to visualize the near iliac crest. I'll show in the video. You just place the probe above the iliac crest, and you can see and compare the image and slide the probe medially. We'll try to get the oblique muscles. You can see the hypoechoic structures crossing there in the tab plane. This may, along with the nose, you can see the vascular structure. This is deep inferior circumflex artery. So always be careful during the ilioinguinal and iliohypogastric nerve block, which needs careful aspiration before depositing the drugs. You can see the block. Keep the iliac crest in the vision, because near the iliac crest, the nerves entering the tap plane. So here you may not be able to visualize the nerves, but it is all not necessary always to deposit near the iliac crest. That is a very important point. If you deposit near the iliac crest, you can easily block the ilioinguinal and iliohypogastric nerve. It also provides a somatic anesthesia for the incision in the right or left iliac fossa. It is mainly useful in the pediatric inguinal surgeries, appendectomy, and the iliac crest grafting, and use a low volume 0.3 ml per kg because close proximity of the deep circumflex iliac vessels. Quadratus lumborum block, first discovered by is a posterior abdominal wall block discovered by the Rafael Blanco in 2007. A block generated tremendous interest in the last decade, and it provides some somatic and some visceral analgesia. Multimodal analgesia concept, it significantly reduces the opioid consumption. There is anatomy. It arises from the inner rim of the iliac crest and attached to the transverse process of the L1 to L4 vertebra and the 12th rib. Anteriorly related to the psoas major and posteriorly related to the paraspinal muscles. Cross-sectional view. You can see the epimysium of the QL muscle, and in the right side of the image you can see the fascia transversalis as well as the, which is in red in color, and spinal nerve exiting from the intervertebral foramen runs anteriorly into the quadratus lumborum muscles and enter the tap plane. And you can see the internal oblique and transverse abdominal muscles tapering end and forms the aponeurosis. This is a very important landmark. Thoracolumbar fascia is a fascia. It's a complex of facial and aponeurotic tissue. It serves as a conduit to the paravertebral space, and it is rich network of sympathetic fibers, mechanoreceptors. So blockage of this provides good analgesia. Thoracolumbar fascia divides into 3 layers: anterior, middle, and posterior thoracolumbar fascia. You can see anterior thoracolumbar fascia medially attaches with the fascia of covering the psoas major, and laterally the attached with the fascia transversalis. You can trace here. This is a fascia transversalis. Anterior thoracolumbar fascia attaches with the thoracolumbar fascia, and middle thoracolumbar fascia it separates the QL muscle from the erector spinae as well as the latissimus dorsi muscle. You can, here is the lumbar interfacial triangle for the posterior quadratus lumborum block. You can deposit the drug here. And posterior thoracolumbar fascia attaches with the spinous process. What are the common indications? Midline laparotomy, infraumbilical procedures like TAH and LSES, abdominoplasty, all renal transplant and nephrectomy surgeries, and abdominal, iliac crest bone grafting and hip surgeries. Recent study shows it provides analgesia to the hip surgeries also. So these are different locations and types of blocks. Lateral is otherwise called QL1, and posterior is otherwise called QL2, and anterior is otherwise called QL3. So QL1 is lateral. You can deposit the drug near the lateral border of the quadratus lumborum muscle. Near the lateral border of the quadratus lumborum muscle. Actually, the injection should result in the visible spread of the drug near the ventral surface of the quadratus lumborum. This is QL1. QL2 is posterior to the quadratus lumborum and anterior to the erector spinae muscle. In between these muscles, you can deposit the drug in QL2. QL3 is anterior QL. You deposit the drug in between the psoas major and the quadratus lumborum. Requisites for the block: standard Stimiplex needle 100 mm or epidural needle, and the volume for the block is 30 ml of local anesthetics. And you can perform the block either in supine or lateral position, but supine position for QL and QL2 block, but for QL3 or anterior approach always needs lateral position and always needs curvilinear probe. So important point in supine position, always place the wedge under the hip to get the better visualization and for working space to perform the block. Supine position always in the left side of the image, needle entry from the lateral to medial. Always follow this, better avoid medial to lateral entry to avoid the visual organ injury. You can see the typical, in some patients, you can see the typical Google location sign. A QL muscle is always hypoechoic, and frequent scanning, we can able to identify the QL muscle. This is the anterior, lateral, for the lateral QL block, patient in supine position. Place the probe just above the iliac crest. You can see the QL muscle, hypoechoic QL muscle in the Google location sign, and psoas major, and the oblique muscles, and the fascia transversalis below the transverse abdominis muscle. Here, the lateral or QL1 block, the needle is entering from the lateral to medial direction. Try to deposit the drug later near the lateral border of the QL muscle. Here, needle entering from the lateral to medial, advancing the needle and targeting near the tapering end of the oblique muscles. In this image, we went more anterior. You can deposit here. Here we went little more anteriorly, but better deposit near the tapering end of the quadratus lumborum muscle. You can see the opening of the separation of the layers here. Then spread of the drugs towards the lateral edge of the quadratus lumborum muscle. So QL anterior block is otherwise called QL3. Place the probe above the iliac crest. Keep the patient in lateral position. This is traditional shamrock sign. You can see 3 leaves: erector spinae, quadratus lumborum, and psoas major, and transverse process, stem of the leaf. You scan from either anterior to posterior or posterior to anterior direction. If you come more anterior, you can see the tap muscle. If you go posteriorly, you can see the traditional shamrock sign. Here you can see that tap muscles. This hypoechoic muscle is a QL muscle. If you go more posteriorly, you can see the quadratus lumborum. You can see the transverse process also. So try. Here you can see needle needle entering from the lateral to medial direction. So you will cross the erector spinae muscle and try to reach the location between the QL and psoas major, which is called QL3 or anterior quadratus lumborum block. Drug deposition you can see between the QL and psoas major. This is a subcostal approach. We can do either in the lateral position or in the sitting position. Needle entry, we can enter in the 2 way, either cranial or caudal cranial direction in the in plane, or block the use the out of plane technique. Here we used out of plane technique. You start scanning from the midline, the parasagittal probe, place the probe in the sagittal plane and move laterally from the midline. In the second image, you can see the classical trident sign, transverse process, and visceral organ kidney, and the flat QL muscle you can see once you move laterally, and above which you can see the erector spinae and latissimus dorsi muscle. Try to deposit the drug below the QL muscle. You can see the small psoas major here. Needle entering the out of plane technique. You can see the needle tip here. below the QL muscle and above the psoas major, you deposit the local anesthetics. You can see the splitting of separation of the muscle by depositing in the interfacial plane. Always do the saline dissection to confirm the position and use the stimiplex needle. You can avoid the intramuscular injection because the muscle will get stimulated using the stimiplex needle. So in subcostal sagittal plane, parasagittal plane approach, you can get the typical flat sign from posterior to anterior, erectosplenic, QL, and psoas major. The drug deposition site. And the complications includes if you advance the needle to anterior into the psoas major, you will get a lumbar plexus block. Lumbar plexus will get blocked, and some reports shows leg weakness or numbness also possible. Always explain the patient when you do the QL block, and visceral organ injuries with the subcostal approach, and retroperitoneal hematoma also possible. So always QL tips, always scan of the transverse process in order not to hit with the needle. Use a nerve stimulation to ensure the needle tip, and either use the anterior or a posterior approach, but it is difficult in the obese patient. It provides somatic, some visceral analgesia to the T8 to T12 segment, and always enter the lateral to medial direction. Better avoid the medial to lateral direction, and always avoid if the patient is on anticoagulation. It is also considered as a deep-seated block, so follow the standard central neuroxide block guidelines. Definitely take home message. Definitely it is an alternative to the central neuroaxillary paravertebral block, and it is a valuable option in infraumbilical procedures, especially TAH and LSS type of procedures, and minimal or nil side effects with the ultrasonogram guided block. There's few disadvantages, less duration of the block, sometimes up to 6 hours, sometimes up to 12 to 24 hours, but always needs additional opiate recommends after 6 to 12 hours, and cannot use as a sole technique for analgesia, always combined with the multimodal analgesia concept, and continuous catheter technique. We don't have any experience, and it is also complex and challenging because of the interference with the surgical site, wound dressing site, and the chance of infection and the displacement of the catheter in the interfacial plane. So it is always complex and cumbersome to do the continuous block. But in future, the research is going on regarding the local anesthetic additives, as well as the liposomal bupivacaine is increasing the duration of the block. And I once again thank all the Dr. Advajan sir and the entire team. Thank you very much.
Thank you very much, Dr. Vinod. That was a beautiful presentation. I see a lot of hard work behind those slides, and it was absolutely beautiful. Your sono anatomy, the entire illustration, and all the videos were very, very beautiful. And you have answered most of my questions in your last slide. I was about to ask you about the feasibility of continuous block catheter. You've answered that. One question which I have for you, which is the combination of local anesthetics which you would normally prefer?
I didn't get you, ma'am.
What will be the combination of local anesthetics which you will prefer?
Usually we prefer bupivacaine with lignocaine, ma'am.
Is there anything else than your ropivacaine? Anything else?
We used to give 0.2 ropivacaine also. But for the post-operative purpose, better you don't combine the drug.
Okay.
And calculate the dose to avoid the systemic toxicity.
Okay. And this is for the benefit of postgraduates. You were talking about local anesthetic additives.
Yes.
What are the additives which is recently being, which is recent? Any recent updates?
Yes, we commonly use dexamethasone 4 milligram. Even 2 milligram, a lot of studies have done. Even 2 milligram and 4 milligram gives prolonged equal and prolonged duration. We commonly use dexamethasone alone.
Beautiful, beautiful. Thank you so much, Vinod. So proud of you. That was a beautiful presentation coming from Madras Medical College. God bless you. God bless you. Thank you very much.
Thank you. Thank you very much.
Thank you. And on behalf of Professor Edward Johnburn, sir, and our entire team, we would like to tell our postgraduates and consultants here that we are successfully completing our 50 classes and 100 hours of online anesthesia on December 25th. On this juncture, we would like a few words of appreciation and your suggestions and valuable feedbacks and how best we can take forward this program in the oncoming years. You can message it to us directly, or you can post it on our email ID, onlineanesthesia@gmail.com. So with that, this online anesthesia comes to an end. Thank you very much to both our speakers, Dr. Ishwar and Dr. Vinod. It was lovely having you here. And it's a goodbye from all of us today. Online anesthesia sponsored by Accurella, hosted by A1 Logistics, and our telecast partner, Anaesthesia TV. Thank you all very much. Thank you.